The next presentation will be by Dr. Basem Abdelrahman, Fenestrated Endovascular Repair in a juxtarenal aneurysm with concomitant horseshoe kidney. For Basem.
Good afternoon. I would like to thank the organizing committee and special thanks for Dr. Musad Saliman for the kind invitation today. It's my honor to stay here once again among you. My presentation today is a case report, fenestrated endovascular repair in juxtarenal aneurysm with concomitant horseshoe kidney. The horseshoe kidney is a renal fusion anomaly in which the bilateral kidneys are connected at the inferior pool with a parenchymatous or fibrous isthmus, usually in front of the abdominal aorta. And the incidence of these cases about 0.25%, and from these persons there are 0.12% accompanied by aortic aneurysm, and in 60% of these patients have one or more accessory renal arteries. The first description was in 1521 and the first open repair in 1957, and the first endovascular repair was published in 1997. According to Eisendrath classification, there is 5 types of classifications of the horseshoe kidney: type 1 with 1 renal arteries for each side, and type 2 1 renal artery for each side plus and branch to the isthmus; type 3 2 arteries for each sides and 1 for the isthmus; type 4 2 arteries for each side with 1 or more arising from the iliac vessels, including the isthmus branch; and type 5 multiple renal arteries arising either from the aorta or mesenteric or iliac vessels. The diagnosis typically accidentally with ultrasound, and the confirmation of the diagnosis done with computer tomography, and if necessary for assurance of the renal perfusion and for the accessory renal vessels, we can do the selective DSR. We have multiple options of management of such cases, but before all, we should have a good knowledge of the exact anatomy of the renal perfusion, and keep in mind to preserve the large diameter accessory renal arteries that supply a significant percentages, more than 30% of the kidney. Moving through the open procedure, either transperitoneal access with a great advantage of better exposure of the abdominal cavity and the aneurysmal sac, but we have a limitation when we need to expose the complete exposure of the iliac vessels, we could injure the isthmus. And retroperitoneal access, in my opinion, it had a limitation access in such cases of exposure of the contralateral iliac vessels, but it gives us a better chance to reanastomose the accessory renal arteries. The endovascular procedure with the advantage also of short hospitalization and reduction of the perioperative mortality and morbidity, and the disadvantage it's the technical concern in treatment of the variable renal vasculatures and maybe lead to renal impairment post-operatively. The techniques of endovascular management, either traditional P-iliac EVAR procedure or mono-iliac endograft with crossover bypass. We have also fenestrated EVAR and with chimney technique. The hybrid operations is combination of EVAR and surgical management was described in 2 cases in the literatures. One of these cases was a reimplantation of a large accessory renal artery to the external iliac artery using a venous graft, and in the other report was where 2 accessory renal arteries reimplanted with a Dacron graft. Till 2029, there was 6 documented cases managed by Fenestrated EVAR, 3 of them in 2014 and 2 cases 2020 and 1 case 2029. And it's my pleasure today to show the 7th case of the wallet done in our hospital in 2023. We had a 62 years old patient with completely asymptomatic from the urological department with a risk factor only of hypertension. The examination shows a sonography, partial thrombosed infrarenal aortic aneurysm was approximately 6 centimeter in diameter, and labo was a normal range, and CT morphologically shows that abdominal aneurysm 63 millimeter plus a horseshoe kidney, and this slide shows the diameter of the aneurysm. And we have the right renal artery is above the left renal artery, and for luck it was no accessory renal arteries. We have decided to go for fenestrated with double fenestration of the post-renal arteries, and the operative was controlled general anesthesia with exposure for the femoral vessels under the continuous heparin infusion, and the deployment of the graft and the contralateral side with fenestration for the renal arteries using the steerable sheath. And this slide shows accurate measurement of the abdominal aorta in different levels above and below the renal arteries. And this slide shows the intraoperative fenestration of the renal arteries and the complete deployment of the anaconda stent. And the intraoperative control after complete deployment of the graft. The duration of the operation approximately 2 hours 45 minutes with fluoroscopy time of 22 minutes. Post-operative 1 night of intensive care, and the labo showed no renal impairment, and the CT control shows post-operative showed the proper insertion of the endograft, and with no evidence of endoleak, and that discharge was in 4 days after the operation, and the CT control months later. The summary for today: the proper knowledge of the morphology and renal perfusion in such cases is a must, and fenestrated EVAR is an elegant and minimally invasive method for the elective elimination of aortic aneurysm in concomitant horseshoe kidney. Thanks.